So we are also live on YouTube. I have posted the link on our chat box, but that is purely for your reference in future. If you want to be certified, ensure you join through Zoom and not through the YouTube link. Yeah, but we are live from there. You can watch through Lab Medicine Society of Kenya. You can also find our past webinars there. There are those of us who keep asking that they want to join the webinars and they don't want to pay or they don't want a certificate. We have the presentations on YouTube. You can go there and just watch. So otherwise, welcome, Collins.
Are you able to see my screen?
Yes, we are able.
Thank you. So welcome, ladies and gentlemen. My name is Oduor Collins Abonyo. I'm a lecturer at Alupe University. I'm a hematologist and, of course, medical laboratory scientist by profession. So today's presentation is on laboratory diagnosis of hemostatic disorders from platelets to coagulation pathway. So what is the rationale for this topic? Having information on laboratory diagnosis, on hemostatic disorders, on platelets and coagulation, integrates theoretical principles with practical laboratory application. Equip us with the skills to understand test rationale, perform accurate interpretation, uphold diagnostic and quality assurance standards. It also bridges the critical gap between laboratory practice and clinical decision-making to enhance patient care outcomes, because that is our core mandate. So what are the objectives for today? The first objective is to define hemostasis. Two, to describe mechanisms involved in hemostasis. To identify the coagulation factors involved in each of the coagulation pathways, and also to talk about the coagulation pathways, talk about the disorders, and the screening tests. So by the end of this session, you will be able to accurately define hemostasis, describe mechanisms involved in hemostasis, list coagulation factors, explain how intrinsic and extrinsic coagulation pathways lead to the common coagulation pathway, and also be able to discuss the hemostatic disorders and their diagnosis. So what is hemostasis? So this term hemostasis is actually an ancient Greek word, and it's a combination of two Greek words. The first one is hem, and the second one is stasis. Hem means blood, and stasis means to stop or stand still. So hemostasis therefore means, in a layman's language, stopping of blood. So some of the sampled definitions of hemostasis. One, it is a complex process which prevents spontaneous blood loss or stops hemorrhage when vascular system is damaged. The other definition is arrest of blood flow and control of hemorrhage from injured blood vessels. You can also define hemostasis as a process by which bleeding at any site is arrested by formation of hemostatic plug. So what is the aim of hemostasis? One is to seal ruptured vessels. And why? So as to prevent further loss of blood in order to maintain blood flow within the circulatory system. Now, to what extent is hemostasis effective? Hemostasis has proven to be effective in dealing with small and simple wounds. And that means in case of a damage or a rupture of large vessels, then there will be need for medical intervention. Now, what are the necessities and classification of hemostasis? So for hemostasis to successfully take place, there must be blood vessels, platelets, and coagulation proteins. And hemostasis is classified or categorized into two: primary hemostasis and secondary hemostasis. So what are the elements of primary hemostasis? The first one is local vasoconstriction, and the second one is formation of a platelet blood. And the secondary hemostasis is actually the progression of the coagulation cascade, resulting in the formation of an insoluble fibrin mesh to strengthen the platelet plug. Let's try to hide this. Now, what are the mechanisms involved in the hemostatic process? Now, the complex hemostatic process is initiated following vascular injury. So there must be an injury to the vessel for hemostasis to be initiated. So following injury, what happens? Vasoconstriction. The blood vessels constrict so as to reduce blood loss from the circulatory system. So vascular factors that reduce blood flow are actually two. One is that the vascular compression takes place, and this is by the extravasated blood into the surrounding tissues. We understand that when a vessel is ruptured, then blood will tend to flow outside the circulatory system. And of course, they tend to occupy the space outside the blood vessels. So when that occurs, will lead to compression of the vessels, and that ultimately reduces blood flow. Then the second one is vasoconstriction. So this is done by several vasoconstrictors. Here are four. One is the endothelin. Endothelin is a protein hormone that is released by the endothelial cells. And the other one is thromboxane. Thromboxane A2 is actually released by the endothelial cells and also released by platelets. And then the other one is adenosine diphosphate, which is released by platelets. And the last one is serotonin, which is also released by platelets. Now, talking about endothelin, endothelin is a protein, and we are saying it's produced by endothelial cells. So it means these endothelial cells, of course, they have the nucleus, and the nucleus has chromosomes, and the chromosomes have the genes, and the genes are specific. So there is a specific gene in endothelial cells that is able to be transcribed into mRNA and translated into a protein endothelin that then helps in constricting the blood vessel to control blood flow in case of a vascular injury. And that also happens with the production of thromboxane A2 by the endothelial cells. But what about the platelets? Platelets are actually enucleated cells, and they are products of a rupture of a megakaryocyte with platelets. So it means this thromboxane A2 is produced by the immature forms of thrombocytes, and then they are packaged in the platelets to help perform this function when need arises. Adenosine diphosphate, serotonin also produced in the same way. Now, what is the mechanism of the mechanism by which vasoconstriction takes place? Now, when a vessel is severed or damaged, pain receptors and constrictors, more so the endothelins, are believed to trigger vascular spasm, which is the dramatic contraction of smooth muscles in the walls of the vessel. So we'll share this presentation and you'll be able to watch the video on YouTube that will help you get privy to vascular spasm. Then the second step of hemostasis under primary hemostasis is actually the formation of platelet plug. So how does the platelet plug form? It begins with platelet adhesion to the subendothelium. Injury to the vessel damages the vascular endothelium and exposes collagen fibers. Take note of collagen. Then adhesion can either be direct or indirect. Direct platelet adhesion. Platelet adhesion mediated by platelet surface glycoproteins. The platelet surface glycoproteins like glycoprotein 6 and integrin alpha 2 and beta 2 bind collagen. So it means platelets have certain molecules that they express on their surface, and they are glycoproteins, a combination of carbohydrates and proteins. And they can directly adhere to collagen, and this collagen is exposed on endothelial cells when there is a damage on the vessels. Then the other mechanism by which a platelet can adhere to the site of vascular injury is indirect. And indirect adhesion is mediated by von Willebrand's factor. The von Willebrand factor is also just a protein that is produced through the same way, through the gene expression. And it is primarily produced by the endothelial cells. So the endothelial cells release von Willebrand factor multimers, and von Willebrand factor multimers bind to the exposed collagen, while some released into circulation. The von Willebrand factor binds to glycoprotein LB, that is labile, on platelet surface membrane, leading to adhesion. And take note that some of the von Willebrand factors released by the endothelial cells are actually released into circulation and they bind factor VIII. So it means factor VIII does not just exist freely on its own in the circulatory system. A continuation of formation of platelet plug. So once adhesion has taken place, that results in platelet activation. Are you together? Moderator, are we together?
Yes, we are. We are.
Thank you. Thank you. Okay. So once platelets have adhered, then they get activated. Now, platelets are actually enucleated cells, and keen examination of the intracytoplasmic content of platelets reveals 3 types of granules. The first one is lysosomes. The second one is the dense granule. And then the third one is the alpha granule. Now, what are the key contents of these granules that play a role in hemostasis? The lysosomes actually contain hydrolytic enzymes. And hydrolytic enzymes, of course, are those that help the cell digest food, help the cell fight bacterial infections, and the rest. But the key ones are found in dense granules and alpha granules. So the dense granules contain adenosine diphosphate, contain adenosine triphosphate, contain calcium, which you know is a key element for coagulation. It also contains serotonin. The alpha granules contain platelet factor 4, contain platelet factor 5, von Willebrand factors, the fibrinogen, and fibronectin, which facilitate adhesion and aggregation of platelets. So just the same way, von Willebrand factors are also, once synthesized, are taken to be stored within the granules of the platelets to help platelets perform their hemostatic function whenever need arises. Now, platelet activation leads to a change in shape of platelets. When platelets are not activated, they are disc-shaped. But the moment there is activation of platelets, then they change shape into spiny spheres that are more sticky than the disc-shaped. And once they are activated, they also release the granular contents, the ones we've just discussed above. They include the serotonin, thromboxane 2, ADP, ATP. Now, what are the roles of these granular contents? Why are they released? They are released so as to activate nearby platelets around, also to facilitate aggregation at the site of injury, and also to help promote stimulation of coagulation pathways. Now, the platelet aggregation, formation of platelet plug takes place after the activation, after aggregation, and as more platelets adhere and get activated, they clamp together and eventually form a platelet plug. Now, the glycoprotein receptors, the GP2B and GP3A, bind platelets together, forming platelet aggregates. Now, what does this mean? It means platelets are involved in hemostatic role, but on their surfaces, they have to communicate to each other. So they tend to express certain molecules on their surfaces, including glycoprotein 2B and 3A. So those glycoprotein, they tend to interact when the platelets have changed shape due to stimulation as a result of vascular injury. And that helps them aggregate at the site of vascular injury. Fibrinogen forms bridges between activated platelets to form a stable platelet plug. Now, platelets are activated, they have aggregated, there is a formation of a strong platelet plug. But then there is another thing missing. There must be formation of a mesh network within the platelet aggregate to form a strong plug that will stop blood flow outside the circulatory system. So the next stage is the coagulation. And coagulation is actually the formation of insoluble cross-linked fibrin polymers by activated coagulation factors. And what is the goal? The goal of coagulation is to stabilize platelet aggregate by weaving a mesh of fibrin to cement the thrombus. So what are the factors involved in coagulation? Now, just an introductory part of it. Through international agreement, coagulation proteins are designated by Roman numerals from factor 1 to factor 13. Now, take note that they are numbered 1 through 13 according to the order of their discovery. And you should also note that the order of discovery does not reflect the reaction sequence, as we shall see when we'll be discussing the coagulation pathways. Now, also take note that factor 6 is non-existent. Factor 6 was once believed to be a distinct clotting factor, but it is now thought to be identical to factor 5. And why is it that it was not scraped off? It's because the factor 6 had to be left as a reminder that knowledge changes over time. Now, here is a list of coagulation factors, bearing in mind that the process of coagulation requires vitamin K. So the clotting factors include factor 1 is actually the fibrinogen, and it's a plasma protein primarily produced by the liver. And it functions in the common pathway, and it's converted to fibrin mesh. Then there is factor 2, which is the prothrombin. You also see it's produced by the liver. Then factor 3 is the tissue thromboplastin or tissue factor, which is also produced by platelets and damaged cells. So as we continue, you will get to realize that the extrinsic coagulation pathway is actually activated by the tissue factor, the thromboplastin or the tissue thromboplastin or tissue factor or factor 3. And you can see the source. The source is damaged cells and platelets in the extrinsic pathway. Then there is factor 4. Factor 4 is actually the calcium ion. Calcium ion we get from diet. We also get calcium ion from platelets, and we also get calcium ion from bone matrix. And it's required for the entire process of coagulation pathway. Then the factor 5 is the proaccelerarin. Proaccelerarin. It's also produced by the liver. It's also produced by the platelets. Then the factor 6, which is not there. We've discussed that. Then factor 7, which is the procovatin, and is produced by the liver. Then factor 8, which is antihemolytic factor A by name, and it's produced by the endothelial cells and platelets. Take note of the source. Factor 8 is produced by the platelets and endothelial cells. Then there is the factor 9, which is also produced by the liver. Then there is factor 10, which is also produced by the liver. Factor 11 produced by liver, factor 12 by liver, factor 13 by liver and platelets. So throughout this process, you appreciate that most of the coagulation factors are primarily produced by the liver, and a few produced by other cells, including platelets and endothelial cells. Now, coagulation pathways. There are 3 coagulation pathways: the intrinsic pathway, extrinsic pathway, and the common coagulation pathway. Now, what are the key coagulation proteins or coagulation factors that are involved in the intrinsic coagulation pathway? They include factor 12, factor 11, factor 9, and factor 8. Extrinsic coagulation pathway factors include tissue factor, which is also the factor 3, and also the factor 7. And then the common pathway clotting factors include factor 10, factor 5, factor 2. Factor 2 is the prothrombin, and factor 1, which is the fibrinogen. Now, activation of clotting factors. Activation of clotting factors require phospholipid source, which include phospholipid surface, which can either be tissue factor, and the tissue factor is factor 3, and that plays a role in the extrinsic coagulation pathway, and also the activated platelet, which is platelet factor 3 phospholipid, which activates the intrinsic coagulation pathway, and there is need for vitamin K. Now, vitamin K is gotten from diets, and it's a very essential vitamin in the synthesis of factor 2, factor 7, factor 9, and factor 10. So if you don't have enough vitamin K in your system, then obviously you'll suffer a coagulopathy, or an abnormality of the coagulation pathway. Then formation of reaction complex, the labile factors, factor 5 and factor 8. You'll see their position and their role in the coagulation pathway. Now, factor of extrahepatic origin. This is factor that is not produced by the liver, is factor 8. Factor 8 has got two components that are controlled by two different genes. So there is the factor 8 RAG, that is it is a factor 8 antigen that is bound to von Willebrand factor. Then there is also the factor 8C, which is the coagulant, which C specifically means coagulant activity. And as you can see, the absence of factor 8 results in hemophilia A. We'll discuss that when we're looking at the disorders. Then the other one is the von Willebrand factor, which we said is produced actually by the endothelial cells, and it's also stored in the platelet granules and released when there is need. So what is the function of von Willebrand factor? One, it mediates adhesion of platelets to surface collagen. Remember the indirect adhesion. Then another function, there is also the von Willebrand factor appears to have defect in primary, von Willebrand factor appears to have defect in primary hemostasis and hemophilia A. Why? It's because hemophilia A is actually the deficiency of factor 8. And factor 8 exists in collaboration with von Willebrand factor. So if there is a genetic defect that affects the synthesis of von Willebrand factor, then of course, there will not be functional factor 8. So they act together, but controlled by different genes. And if either of the gene is affected, then that will lead to an abnormality. So abnormality of factor 8 is hemophilia A, and abnormality of genes controlling von Willebrand factor is von Willebrand factor disease. Coagulation pathways. That is the diagram. So coagulation pathways, we have intrinsic pathway, extrinsic pathway, and the common pathway. So activation of the intrinsic pathway begins by a vascular injury and exposure of high molecular weight kininogen, which act together with prekallikrein to activate factor 12 into activated factor 12. The activated factor 12, in collaboration with calcium ion and high molecular weight kininogen, activate factor 11 to activated factor 11. Activated factor 11, together with calcium ions, activate factor 9 to activated factor 9. Activated factor 9, together with activated factor 8, calcium ion, and platelet factors, activate factor 10 to activated factor 10. And activated factor 10, in collaboration with activated factor 5, calcium ion, and platelet factor, activate prothrombin to thrombin. Then thrombin activates fibrinogen, thrombin activates factor 5, thrombin activates factor 8, thrombin activates factor 13. Then thrombin also activates fibrinogen by cleavage. It cleaves fibrinogen into fibrin monomer. Now, fibrin monomers pile to form fibrin polymer. But this fibrin polymer is soluble, but we need an insoluble fibrin polymer to cross-link the platelets. So activated factor 13 by thrombin then converts fibrin polymer into the insoluble fibrin polymer into a soluble fibrin polymer that then cross-link platelets to form the firm platelet plug that then seals the site of vascular injury. Now, in a normal state, when the vessels are injured and the coagulation process has taken place and the site of injury is sealed and blood flow is maintained within the vascular system, two things occur. As time goes by, the healing process takes over and the fibrin also has to be lysed. So as the tissues, the cells surrounding the site of injury can undergo mitosis, they multiply and cover the site of injury as if there was no injury at the site. So fibrinolysis is the next step. Fibrinolysis is a physiological process that occurs simultaneously with healing. And what is the aim? The aim of fibrinolysis is to remove insoluble fibrin deposits following plasminogen activation. So in the circulatory system, there is the plasminogen. And plasminogen is cleaved to form the plasmin. Inactive plasminogen is cleaved to the active plasmin by activators. So there are two major types of activators: the tissue type plasminogen activator and the urokinase type plasminogen activator. The tissue type plasminogen activator is the most active and it's more produced by endothelial cells compared to the urokinase type plasminogen activator. Now, the role of these activators is basically to cleave plasminogen into plasmin, and then plasmin degrades the fibrin into intermediate X and Y fragments. Then X and Y fragments are further degraded into smaller D and E fragments. And these fragments exert an antithrombin effect, inhibiting clot formation, thus reopening the blood vessels if they were blocked. And it is expected that in a healthy individual, when you take 4 ml of plasma, the amount of D dimers should be less than 1 microgram. Now, we just talked about the intrinsic coagulation pathway. What about the extrinsic coagulation pathway, which also once is formed undergoes the same process? So extrinsic coagulation pathway. Now, extrinsic coagulation pathway begins with activation of factor 7. Activation of factor 7 is actually caused by the tissue factor.
So to those of us who have just joined, we are proceeding well with the presentation. And I just made an announcement that this presentation is also available on YouTube Live, so that if you want to make a reference to it, You can always, after the presentation, you can always go back and just watch or just make reference to the presentation. Also, I've said that when you watch through YouTube, it will not make you eligible for a certificate because we have to track attendance, which YouTube does not. So for that purpose, we strictly use Zoom to attend if you want to be issued with a certificate, and also if you want to be eligible for the 3 CPD points. Also, if you are paid and you are not able to join in this live webinar, you are allowed to watch because we do recorded versions. So a recorded version will be there today. Unfortunately, for today's version, we shall close watching of the webinar or of the recorded version at exactly 6 p.m. So in case you want to watch, kindly watch up to 6 p.m. After that, we shall disable the recorded version so that those who will have watched by then are the ones who will be eligible for the certificates. So I think we are proceeding well. And for those of you who still have concerns regarding regarding your certificates, I've said that you wait for 3 days, and in case you don't receive the certificate, you proceed to raise an issue with us. You can do that by calling the number. We have a complaints number. You can reach out to that number, and then you shall be assisted. Also, many of you are getting issues because of inaccurate details. So ensure that you fill in the correct details on Zoom. Ensure you fill in the correct details on Zoom. So I think with that, you shall be able to be assisted. Also, I want to request you that in case you have logged in your email, also keep checking. Sometimes your certificates go to your junk or the updates or the spam. So just keep checking even before you reach out. Also, every webinar is independent. There are those of you who use payment for previous webinar to claim certificates for current webinars. So ensure that you attach a current payment because we do verification. And as such, we will need a current payment to prove that you paid. Also, I said that you need to attend. Once you pay and you don't attend, we may not be able to issue you with a certificate. Just try and pay and also attend. In case you have challenges, ensure you watch the live or the recorded webinar so that you are eligible for certificates. I think with that, we can proceed. Let me just get the presenter. Had a small challenge. We apologize. The presenter had a small issue, but he's making it back in the next few. So just hold on, be patient as we assist him get his slides.
Guy, what's happening? Yawa. Ah, Guy. Sorry, guys. Sorry, guys. Can we continue?
Yes, please, let's proceed.
Okay, sorry. Let me just share my document. Are you able to see my screen?
Not yet.
And now?
Still not yet.
Sorry, bad weather. Sorry. And now?
Not
Not
yet.
yet.
Not yet.
Sorry. Let me share the entire screen. Can you see the documents?
But
Hello?
We can't see them.
You can't see?
No, we can't.
It's serious. So it is possible to use a phone, isn't it? And now?
Not yet.
Wow. There's actually no power around my place. So I'm trying to use my phone. Share whiteboard. Please just let me know if you see the document. It's serious. Just be patient, please. And now?
We can't see.
You can't see. Okay, you can see my screen or not necessarily the document,
we can see the whiteboard.
the whiteboard.
Yes.
Okay. I want to share a document. Wow, this is serious. Microsoft Point.
Check WhatsApp, Collins.
Yes, I check WhatsApp. You said I check my WhatsApp?
Yes, Collins, check your WhatsApp.
Whose account at the LMSK webinar?
Please do.
Okay, yes, I'm there. Okay. Okay, Obade.
Can see still. Collins, can you just send the PPT? Collins? Collins? You can hear me, Collins? Collins, can you hear me? To everyone, again, we want to apologize for this. Sorry for the inconveniences. We dearly apologize that we were able to lose the presenter. He has communicated to us that very heavy rains have just affected where he is. And we are working on having him here shortly. I think we are almost there. So I want to request for your patience. And once again, I want to apologize for this because it has taken a bit of our time, and we are resolving it shortly. So once again, in case you just missed out, the presentation will be available on YouTube. You can just go back and maybe watch. And as I said earlier is that this webinar will attract 3 CPD points. And just in case maybe you are not able to join, we have a recorded version that you can watch up to 6 to today, and we shall award you CPD. Are you back? Collins? We are fixing this shortly, and you shall bear with us. It's quite a new terrain for most of us. And as a result, maybe there may be certain challenges along the way. But you can be sure that with the time, we shall be able to overcome all these challenges. You know that the issue of CPDs and where these maybe type of meetings are still a terrain that we are not very familiar with. But I think with your support, it's been an incredible journey. And I think we are there now. So I want to take this opportunity once again to apologize again for all the inconveniences that have happened today. And I think we are now able to project the slides, and we are also able to proceed. So I want to invite you to just be patient so that we can finish the presentation, so that we can just benefit from what we were to benefit from today. So Collins, if you can hear me. Collins?
Collins can unmute, then proceed.
Okay. I hope you are able to hear me now.
Yes, clearly.
Yeah, Collins, you can guide where you left from.
Yes, I left from
proceed.
intrinsic. Just check the coagulation pathway. There's a lot of rain here. Just check the coagulation pathway. Yes. So let's proceed. Sorry for that. Just the diagram that has the pathway. Just go on a little bit. The next one. Yeah, that one, exactly. So, sorry for that, ladies and gentlemen. Let's look at the extrinsic coagulation pathway. So, extrinsic coagulation pathway begins by a vascular injury. And when the blood vessel, the reason as to why it is called intrinsic pathway is because not all elements of extrinsic coagulation pathway are readily available within the circulatory system. While the elements required for intrinsic coagulation are readily available within the circulatory system, those that initiate extrinsic coagulation pathway do not readily occur within the circulatory system. So it begins by the blood vessel injury. Yes. What has happened? Hello? Hello?
I can hear you, Collins. Just a minute. Just a minute.
Okay. Nice. Can we proceed?
Yes, please proceed.
Okay. So I was saying that we have the intrinsic pathway, we have the extrinsic pathway, and we have the common pathway. We have talked about the intrinsic pathway. The reason as to why that pathway is called intrinsic is because all the elements required for coagulation process to take place are readily available within the circulatory system. However, for the extrinsic coagulation pathway, not all the elements required for coagulation process to take place are readily available within the circulatory system. So it begins by an injury to the blood vessel, and then activation of the tissue factor 3. And then the tissue factor 3 activates the readily available factor, activates factor 7 into activated factor 7. Then activated factor 7 activates factor 10 to activated factor 10. Now, you can also realize from the diagram that factor 7 activated also has the ability to activate factor 9 into activated factor 9. So that means if you have a deficiency in factor 9, coagulation pathway may still proceed. And the deficiency of factor 9 is actually called hemophilia B. So if you are deficient of factor 9, you can still have your blood clotted when need be to stop excessive blood loss. Then activated factor 10 activates prothrombin into thrombin, and the process continues as we had explained before. Let's move to the next slide, please. Next, we have talked about fibrinolysis. Next. Yes, coagulation system. Now, there are those elements that activate the coagulation system, and there are those that inhibit the coagulation process. Now, the activators of coagulation process include phospholipids, calcium, iron. And then the inactivators or inhibitors of clotting process include protein C, protein S, tissue factor protein I, alpha-2 microglobulin, alpha-1 antitrypsin, C1 inactivators, and then fibrinolysis. The activators of fibrinolysis include factor 12 activated, factor 11 activated, the activators of this is tissue type plasminogen activator, which activates fibrinolysis. Then the urokinase plasminogen activators, which also activates fibrinolysis. And we said the tissue type is predominantly produced by the endothelial cells, while the urokinase type plasminogen activator is produced in small amounts by the endothelial cells. Then what are the inhibitors of fibrinolysis? They include alpha-2 antiplasmin, alpha-2 macroglobulin, and so on and so forth. Let's continue to the next slide. Now, the key laboratory investigation of coagulation abnormalities. Now, a patient can be examined through wholesomely to the extent that you can identify the specific abnormality, coagulation abnormality that a patient is suffering from. Now, investigation actually begins with the doctor or the clinician. So it begins actually by taking the history of the patient and also getting to know about the symptoms the patient is suffering from. So, for example, if a patient presents to the hospital and is likely to be suffering from a coagulation disorder, then you can look at things like 1, easy bruising, 2, formation of petechiae on the skin, ecchymosis on the skin. You can also look at prolonged, you ask about whether they experience prolonged bleeding when they have undergone maybe surgery or when they are injured, or also prolonged hemorrhage or prolonged what is it called, menstruation for ladies. That can give you a hint that somebody could be suffering from hemostatic disorder. Then, of course, you can also do the physical examination, which, of course, I've explained there. Easy bruising, petechiae on the skin, ecchymosis on the skin, bleeding on the mucosal membranes, and the rest. And then we, as the lab scientists, also have a role in the investigation of these abnormalities. One, it begins by complete blood count. And what do you look at in complete blood counts? You are interested in platelets, which are have a role in hemostasis. Then, of course, platelets, depending on the lab in which you work, it's generally they are about between 150,000 to 450,000 per microliter of blood. Now, if platelets, you are interested in looking at the platelet counts, if they are low, then obviously you will tend to think that this person could be suffering from hemostatic disorder. Then the other test is actually the prothrombin test. Prothrombin test assesses the extrinsic and common pathway, basically looking at factor 7, factor 5, factor 10, prothrombin, fibrinogen, and of course the normal time that is expected when you run a prothrombin test should be between 11 to 13.5 seconds. And then the activated partial thromboplastin test is another screening test for hemostatic disorder. It actually assesses the intrinsic and common pathways. The intrinsic pathway is made up of the factors, factor 8, factor 9, factor 11, factor 12, which we have stated before. And of course, the common pathways will focus on factor 10, will focus on factor 2, factor 1, and even factor 5. Then the others, the normal expected time through the process of intrinsic coagulation is between 25 to 35 seconds, above which you expect a coagulopathy. Then there is the thrombin time. The thrombin time. The thrombin time is a screening test that looks at the abnormalities of the fibrinogen. And the expected time is between 14 to 21 seconds. Then the other screening method is bleeding time. Bleeding time looks at the disorders of the platelets. And when you puncture someone's earlobe, you expect that within 2 to 7 minutes, the blood should have clotted and the site of injury is sealed and this person no longer loses blood. Then the other technique is the D-dimer. D-dimer actually looks at whether there are clots in the system or not. As we have said under the fibrinolysis slides, the fibrin is broken down into X and Y fragments, the intermediate ones, and then further into D and E fragments. And these D fragments, we do the D-dimer tests. If the D-dimer are raised in plasma, then you expect the patient to be suffering from disseminated intravascular coagulation, or the patient has thrombus within the circulatory system, which is thrombosis. Then the other one is fibrinogen. Fibrinogen levels estimation. Fibrinogen is expected to be between 200 to 400 milligrams per deciliter. So if you find that someone has below 200 milligrams per deciliter, then this person could be suffering from hypofibrinogenemia. And if the person is having excess fibrinogen, then could be suffering from disseminated intravascular coagulation. Next. Next, sir. Next slide. Now, what are the disorders that affect hemostasis? One, we should know that disorders of coagulation can lead to uncontrolled hemorrhage into the joints, into the muscles, in deep tissues, forming hematomas. Of course, you know that we can also initiate hematoma during phlebotomy. So all of you know what hematoma is. Now, coagulation disorders are broadly classified into two. There are hereditary disorders and there are acquired disorders. The hereditary disorders are those that we obtain from our parents through gene transmission, and acquired are the ones that we encounter as we develop and grow in our lives. Now, the hereditary disorders include hemophilia A, hemophilia B, hemophilia C, von Willebrand disease, and you shall see the others on the next slide. So let's discuss hemophilia A. Hemophilia A is basically a deficiency of factor 8. Deficiency of factor 8. And where does factor 8 fall in the coagulation pathway? Is it in the intrinsic, extrinsic, or common pathway? Factor 8 is found within the intrinsic pathway. And the intrinsic pathway, the screening test for abnormalities within the intrinsic pathway is activated partial thromboplastin test. And it can also include detection of the specific factor 8. So that is done by factor 8 assay to detect the amount of factor 8 in plasma. Now, what are the expected findings if someone is suffering from hemophilia A? One, you will find that activated partial thromboplastin test is raised beyond 35 seconds. Then you'll also find that factor 8 is reduced in levels. Then hemophilia B is the deficiency of factor 9. And before I proceed, this hemophilia A is also called classical hemophilia. And hemophilia B is also called Christmas disease. Hemophilia B is the deficiency of factor 9, and factor 9 falls within the intrinsic coagulation pathway and is assessed through one, use of activated partial thromboplastin tests, which is expected to occur within 25 to 35 seconds. And it also involves detection, identification, and quantification of factor 9. Of factor 9 in plasma. Then there is hemophilia C. Hemophilia C is the deficiency of factor 11. Now, remember we said that factor 7 activated can activate factor 9. So if someone is having a deficiency of factor 11, can still activate factor 9. Can still activate factor 9 because factor 11 is supposed to activate factor 9, which further activates factor 10. So if you have a deficiency of factor 11, through the extrinsic pathway, activated factor 7 can still activate factor 9. And as a result, hemophilia C is a bit mild compared to hemophilia A and B, just because of that. And how do you assess? You assess by use of activated partial thromboplastin test and detection, identification, and quantification of the specific factor 9. And the expected lab results is that the patient will have raised activated partial thromboplastin test results, and will also have reduced amount of factor 11. Then there is the von Willebrand factor disease. Von Willebrand factor, as we have discussed, it plays a role in aggregation of platelets, and it also plays a role in availability of factor 8 within the circulatory system for hemostatic functions. So deficiency of von Willebrand factor will mean that the gene responsible for synthesis of von Willebrand factor has undergone mutation. Mutation will include things like deletion, insertion, inversion, and all that, even the frame shift and the rest. So someone who has von Willebrand factor deficiency will be diagnosed by use of activated partial thromboplastin test, identification of von Willebrand factor. You can see there it's written von Willebrand factor antigen. So how can you detect an antigen? By use of a specific antibody. So that is basically ELISA. And there is also bleeding time, which you can also use to identify the abnormality von Willebrand factor disease. Next. Now, these are other hereditary hemostatic disorders. So the other one is Bernard-Solaya syndrome. Now, what is Bernard-Solaya syndrome, ladies and gentlemen? Bernard-Solaya syndrome is actually the deficiency of glycoprotein LB. And what did we say glycoprotein LB is? It is a surface expressed protein on the platelets. And its main role is to directly link platelets to collagen when there is exposure due to damage to the blood vessel. They're exposed by the subendothelial cells. Then lab tests for this disease would include one, platelet counts, and of course, platelets levels will be low. Then the bleeding time, of course, will be raised, and then aggregation will be abnormal. Why? Because this protein is expected to enable aggregation. So when platelets cannot aggregate, it means glycoprotein LB is not sufficient. And the only thing that can cause insufficiency of glycoprotein LB is a genetic defect, probably. And there can also be other things, like if there are the genes that are supposed to express these proteins are masked by other molecules. Then the other condition is Glanzmann thrombasthenia. Glanzmann thrombasthenia as a disorder is actually caused by the defect, genetic defects on genes that are responsible for production of glycoprotein 2B and glycoprotein 3A, which we also said help in linking platelet to platelet for platelet aggregation. So obviously you'll get an abnormal aggregation test, and you'll also have, the patient will also present with increased increased bleeding time beyond 7 minutes. Then the other condition is storage pool disease. Now, storage pool disease is a defect of the dense granule. Now, what did we say dense granules are? They are just pockets within the platelets that are actually involved in hemostatic process. How? They release the adenosine diphosphate, they release adenosine triphosphate, they release calcium, and they also release serotonin. Okay? So how can you detect storage pool disease, the deficiency or the defect in the dense granule? One, by conducting aggregation. Why? Because the ADP, serotonin, and the ATP and calcium, they are involved, more so the ADP is involved in the activating platelets and ensuring aggregation takes place. So if the dense granules are defective, then those granular contents will not be released, and therefore aggregation tests will be abnormal. And you can also visualize these granules by use of electron microscopy. So you conduct electron microscopy and you'll be able to see the granules of the platelets and compare those of the patient with those of a normal person. And then there is also a condition called Wiskott-Aldrich syndrome. Wiskott-Aldrich syndrome is actually having patient platelets smaller in size. It's called microplatelets. And how can you detect that? By conducting complete blood counts, checking the levels or the number of platelets, and even looking at the mean platelet volume. That is able to tell you whether platelets are small in size or they are large in size or they are normal in size. And the expected mean platelet volume is between 7.5 to 11.5 femtoliters. Next. Now we said there is also the acquired hemostatic disorders. Acquired hemostatic disorders are those that you don't get from your parents, and they include one, disseminated intravascular coagulation disorders. Now, disseminated intravascular coagulation can be caused by several things. One, cancer. Two, obstetric complications. Three, sepsis, that's bacterial infections, and also trauma. Trauma can cause that because trauma will obviously expose cells and will produce tissue factor 3 type molecules that will initiate extrinsic coagulation pathway, and that will lead to formation of clots that can also can further block the blood vessels, the smaller capillaries. And you know what that can cause? It will obviously deprive oxygen, nutrients, or deprive the tissues oxygen, nutrients, and even ability to excrete waste materials. And that can further lead to weakness and even death of cells. And then laboratory tests include prothrombin time, activated partial thromboplastin test, D-dimer, fibrinogen, platelet count. And those are the expected lab findings. They are raised, except that the fibrinogen levels will be low and even the platelets count will be low. Then there is the liver disease. We've just said that it is the liver that is responsible for producing most of the clotting factors. So if there is liver disease, let's say hepatitis C, hepatitis B, causing liver cirrhosis and the rest, then the ability of the liver to express these molecules will be affected. And that will result in abnormal coagulation ability. And how can you assess that? By using the screening tests, including fibrinogen level determination. So prothrombin time will be raised, APTT raised, fibrinogen reduced, and even platelets counts reduced. And then there is also the vitamin K deficiency. We just said that vitamin K is required for synthesis of factor 2, factor 9, factor 2, factor 7, factor 9, and factor 10. So if there is deficiency of vitamin K, then that will affect both intrinsic and extrinsic coagulation pathways. And when you conduct the screening, you will obviously find those abnormalities. Then there is the TPPP, there is the antiphospholipid syndrome, and there is also the uremia failure. The chronic, the uremia, which is as a result of chronic kidney failure. Now, what is TPP? TPP is, okay, let's continue. Let's just continue to the next. There is also the massive transfusion, there is myeloproliferative disorder, and the rest. Thank you. Thank you, ladies and gentlemen. You'll get time and go through those other ones. They are not very common. Thank you. Moderator.
Thank you, Collins, for the wonderful presentation. And thank you for bringing it out well. I'm sure there are a couple of concerns from our participants. And I'm just going to read a few so that we can also be able to catch up with time. Felix Otieno, distinguish between hemophilia A and B based on lab investigation. So a few concerns. Then I can read the other one. From Ken Achila, what's the mechanism of thrombocytopenia in some cases of malaria? Maybe you can start with those two.
Okay. So it's been researched. You know how research is done. You're talking of malaria infection and also talking about thrombocytopenia. So thrombocytopenia is actually reduced platelet counts. So malaria infection or infestation, just to be specific for the parasites, research has shown that in malaria infected individuals, there is increased risk of thrombocytopenia. And the conclusion in most of the papers is that malaria tend to consume or eat platelets. They tend to consume or eat platelets. And that results in thrombocytopenia. And then for Felix, distinguish between factor hemophilia A and hemophilia B. In terms of diagnosis, did I get it right?
Yes.
Yes, in terms of diagnosis. So, Mr. Felix, hemophilia A is the deficiency of factor 8. Hemophilia B is deficiency of factor 9. Now, from the presentation, both the factors exist within the intrinsic pathway, and both can be screened together by use of activated partial thromboplastin tests. But what draws the difference? Once you have done the screening, then you have to identify the specific factor involved by detecting, identifying, and quantifying the factors. So you can treat this, you can use specific antibodies to detect these specific factors in plasma. Then another thing is that this factor 8, you can also look at its activity so that you can differentiate whether indeed it's because of factor 8 or von Willebrand factor, because factor 8 and von Willebrand factor, they work together. So there could be a deficiency of von Willebrand factor or a deficiency of factor 8. So you have to be keen enough to measure the levels of von Willebrand factor vis-a-vis the levels of factor 8 and distinguish whether it is as a result of von Willebrand factor deficiency or factor 8 deficiency. So in summary, the differentiation of the two is based on detection, identification, and quantification of specific factors. Yes, back to you, moderator.
Mark, what causes epistasis and what's the remedy? What causes hemophilia and what's the remedy? So I think
yes.
I think for hemophilia you have said. Maybe I can add another question because of time. This is from, I think there are so many questions on thrombocytopenia and malaria.
Okay.
And then Gabriel, how do comorbidities such as inflammation, infection, or liver disease, I think that's what he wants to say, alter the interpretation of standard coagulation tests, and what algorithms can adjust for such confounding factors in diagnosis? Thank you, Gabriel.
Sorry.
Did you hear me?
I didn't get you well, sir. Just, sir. Yeah. Just repeat the question. Sorry.
How do comorbidities such as inflammation, infection, or liver disease alter the interpretation of standard coagulation tests, and what algorithms can adjust for such confounding factors in diagnosis?
Just trying to get the key points. Inflammation, like liver disease, Okay. You said how?
How do they alter the interpretation of standard coagulation tests?
Okay, standard coagulation tests. Now, we're talking about the inflammation, liver disease, and the rest. So probably this is, when you talk of liver disease, the liver is the primary producer of coagulation factors. So when it is affected, the health of liver is affected, then probably it can lead to different things. One, there are those effects on liver that might lead to increased production of these factors. And those are abnormalities that would lead to reduced production. So if the liver is affected and is the primary producer of coagulation factors, then obviously the coagulation factor availability within the circulatory system will be affected. And when you talk of inflammation, mostly inflammation is about infections. And infection of cells tend to stimulate production of tissue factor type substances within the system. And those can also alter the coagulation process within the system. And then the remedy for all this is actually management, identification of the abnormalities that are affecting these individuals, and ensuring that those abnormalities are treated. And once treatment is achieved, then those coagulopathies will dissolve just because they are not genetically, there is no genetic abnormality that is involved, but those are acquired problems that can only be managed by treating the patients and so on and so forth. Thank you. Next.
I think there's another question from Owaka Frederick.
Yes.
Can platelets be normal where the patient has bleeding disorders? And then kindly say something on INR and its clinical significance.
Can platelets be normal where? I like writing.
Bleeding disorders.
Can platelet be normal in bleeding disorder? Of course, yes. Yes. Platelets can be normal in bleeding disorders. Why? Because bleeding disorders can be caused by platelets and coagulation factors, or just by the abnormalities of the blood vessels. So if the factory that is producing platelet is normal, then the platelets will be available within the circulatory system in the normal levels. So the coagulopathies could be emanating from other factors other than the platelets. So yes, platelets can be normal in patients with coagulopathies, but those coagulopathies are as a result of other factors other than platelets. And what is the other question?
From Collins Oga, sample integrity plays a role on the accuracy of coagulation results. Please highlight some of them. Accurate diagnosis solely depends on sample integrity.
Sample integrity. I think when you talk of sample integrity, it's about sample integrity begins at the identification of the right test, and also collection of the right amount of samples, blood, and also collecting blood in the right tube. So talking about hemostasis and investigation of hemostatic disorders, we depend on the blue, is it blue topped, the one that contains the trisodium citrate, So if you collect samples in wrong tubes, then of course you're not going to get the right results. If you collect insufficient amount that does not correlate with the amount of anticoagulant, the trisodium citrate in the tube, then you're not going to get the right results. If you collect wrong samples, then that also will interfere with the integrity of the results. And also the clerical errors. If you collect samples and you expose samples to wrong procedures, then obviously you will not get the right results, and you will not provide the right treatment to the patient. So it's revolved around doing the right thing, getting the patient the patient request form, identifying the right test, identifying the right sample, identifying the right collection, good laboratory practice, expose the right procedures, and even the equipment that is used for and also getting to have the right knowledge, skills, and attitudes. And that hey, hello.
Yeah, we keep losing you, but we've had you.
Did you hear me or I repeat?
Yeah, we've had you. We've had you.
Okay, sorry.
Maybe I can bring in, there are still a couple of questions.
Yes.
This is Mike Osita. For the ranges, are they universal or they are determinants like age, gender, and geographical locations?
Age, gender, and geographical
Locations.
Come up again for the determinants.
For the ranges,
For the ranges,
are
okay.
they universal or they are determinants?
Oh, they are called the confounding factors. Yes. Gender can be a confounding factor. Age is a confounding factor. Geographical location is also a confounding factor. And that is why we talk about the range, not specific value. We talk about the range because of the confounding factor. Osita knows very well that in research, when you talk about range, it means there are those confounding factors that can lead to deviation from the norms. So yes, those factors can affect the levels, and as a result, we rely on range. At the same time, it's also dependent on the equipment. The equipment we use also tend to have different ranges. So the ranges used for patient screening will also be specific to the type of machine that is used in a specific lab. Yes, back to you.
Yeah, that's okay. Tobias Yatich, a patient came to the facility.
Yes.
And he had dental issues. So the dentist did for her extraction. After that, the patient kept on bleeding, even after being given tranexamic injection. I think that's what he wants to say. What could the patient be lacking?
Okay. So the patient has undergone surgery, minor surgery, and the tooth has been extracted. Am I correct?
Yes.
And the patient continues bleeding.
Yes.
So when we started by saying hemostatic disorders are associated with prolonged bleeding. So the cause cannot be specific until further investigation is done. So you have to run all the screening tests and compare and contrast with the physical presentations of the patient and even the history of the patient. So indeed, you cannot just land on a specific cause until you run all the screening tests and get to identify the immediate or the major cause of the abnormality. Back to you.
Thank you. Maybe we can take one more.
Yes.
It's from Dennis Alulu. Okay. Let me read this too. Owaka Frederick. Personally, my platelets level is always below the mark, and I'm not suffering from any bleeding disorder or disease. What may be the indication? So, thank you, Frederick. Is there a relation between hemostatic disorders with age, gender, and race?
That is what I just explained, right?
Yes.
Yeah, it is more or less the same as what Michael Sita asked, isn't it?
Sure, sure. Maybe you can attend to Owaka.
Yes.
Owaka is about the platelets level are always below the mark and not suffering from any bleeding disorder or disease. What may be
Yeah.
the indication?
What may be the indication? So platelets are low, but the guy is not suffering from any hemostatic disorder. So one, the decreased platelet counts can be as a result of suppression within the bone marrow, because that is the major producer of course, it's actually the producer of platelets. We know about it's called erythropoiesis. Hematopoiesis. So that is basically thrombopoiesis. So when you talk about an individual having low platelet count, despite not suffering from any hemostatic disorder, then probably it could be emanating from the factory that is producing platelets. There can be some suppression, and suppression can be as a result of, let's say, viral infection. And if this person does not have any viral infection, then it can be as a result of deficiency in certain vitamins, because we know that vitamin B12, folic acid, iron, they're major nutrients that are required for development, growth, and survival of cells. More so, vitamin B12 and folic acid, very key nutrients in the maturation of nucleus of thrombocytes. So if this person could be suffering from maybe nutritional deficiencies, and probably this person could also be having some autoimmune condition that that is not that severe. He could be producing certain antibodies against the proteins that we just said that are found on the surfaces of platelets. And if there is antigen-antibody interaction, then what do you expect? The cells are likely to be broken down and destroyed, and this person could be having reduced platelet counts. Now, what are the things that can cause that? I think probably those, because this person has not presented in the hospital due to some morbidities. So it can either be nutritional deficiencies or the immune system producing antibodies against those platelets. Thank you. Next.
Yeah, I think that's all. We in the interest of time,
Yes.
I know we have a bit because of the hiccups that we had in between the presentation.
Yes.
And take this opportunity to thank all of you for being patient with us and for attending and listening throughout the presentation until you come to the end. And I think this brings to the end today's webinar. I want to just give the presenter for a word, if he has any word, and then I make a few announcements and then we end this.
Thank you, sir. First of all, I hope all of us acknowledge that there can be internet interruptions. From where I am, there's been a lot of rains, and that has really affected the process, but we thank God that it's been a success. Two, I thank all of you for listening and also getting to share the information that is there. And I want to thank the society for the initiative that they have undertaken so that this initiative is bringing us together, bringing about networking and making us a community that is interested in serving the community. So I thank you so much, and we'll always be ready to present some other time when called upon. And that's all. I'm grateful for the day.
Thank you very much, Collins. And on behalf of the Lab Medicine Society of Kenya and all the 2,900 participants who logged into this Zoom webinar, we want to say thank you very much. And at this point, allow me to just share that this session is there on YouTube, and we shall shortly share the recorded version so that if there's any point that was not clear, you can go and watch for clarity. And maybe if you are not able to join the conversation, you can still pay after this webinar and watch. And the platform Zoom will be able to transmit to us your attendance details. Otherwise, we look forward to you having your certificates. But as I said, as when I was beginning this conversation, this webinar was to be a Monday webinar, and therefore we shall proceed with the next series tomorrow. So you will see our alert, so don't be worried. Your certificates are still on the way. Otherwise, thank you very much. And on behalf of the Lab Medicine Society of Kenya, we say thank you very much. See you next time.